Hello, everyone. So today I will be discussing Module 12, and the first chapter that we're going to be discussing is Chapter 39, which is promoting oxygenation. So, what is oxygen? Oxygen, or O2, is a gas with no taste, odor, or color. The most important basic need for life. So if there's no oxygen, we cannot breathe. So absolutely, our cells, right? Our cells we're gonna uh, die. It's because of the carbon dioxide in our body. So oxygen is the most important basic need for life. So death occurs within minutes if breathing stops. So, again, as we have learned from our module 3, circulation, right? Respiratory system. So, they go hand in hand. They compensate with each other, the heart and the lungs. So, brain damage and serious illnesses can occur without enough oxygen. So you assist in the care of persons who have oxygen needs. So in your care, either you're going to be in a home care or you're going to be in the facility, you're going to be assisting clients or residents that have oxygen needs or have oxygen therapy. Okay, so as with any task, before assisting with or giving care related to oxygen needs, you must know the following. Does your province or territory allow you to perform the task? So, as we have described, as we have discussed before, different province and territories, different legislations, right? So, you have to know your job description as well as your scope of practice. Is the task is in your job description? So, as I have mentioned a while ago, that you should know that one if it's part of your job description. Do you have the necessary training? So, again, as with the medications, remember, Module 10, you can be delegated, but it is not a part of your scope of practice. But you can be delegated by registered staff, the registered nurse to administer medication. So your task or your role is to assist in medication management. So, do you know how to use the equipment? So, again, proper training, right? Have have your reviewed the task with a nurse. So you have, I think this is the one when the nurse try to educate you or train you, you're gonna have a return demonstration. So the nurse can, evaluate if you are competent enough to um, assist with the therapy. Have you been supervised by a nurse or respiratory technician for that task? So all of this is these are the questions that you're gonna be asking before assisting or giving care. Okay, with oxygen needs. All right. So um, the administration. So, what is oxygen therapy? So, oxygen therapy is the administration of oxygen to a client in concentrations greater than those found in room air. So, room air is 21%. Okay, room air is 21%. But for some reason, we need more than 21% for several reasons. Let's say illnesses, right? Diseases. So we need more than the person cannot uh, adequately. I think the term adequately able to sustain the 21%, which is the room air. So we need oxygen therapy. All right. So oxygen therapy is the administration of oxygen to a client in concentrations greater than those found in room air. So, a physician or a nurse practitioner can prescribe oxygen therapy. A respiratory therapist is a regulated professional who evaluates, treats, and maintains heart and lung function. So the client should only receive the amount of oxygen ordered. So if the physician or the nurse practitioner, for some reason, the respiratory therapist uh, able to talk it out, like suggest the respiratory therapist suggest this is how much is gonna be the oxygen administration, and the physician and the nurse practitioner were gonna prescribe. Okay, so whatever. For example, in my practice, the doctor will gonna prescribe for let's say my resident is desatting. So when you say desatting, the O2 sat is below, okay, the acceptable range. So let's say 78 is the autosat, the normal is 95 to 100, so that is very low. If the client already have this 80 oxygen level in the circulation or in the blood, pretty much the person is a little bit cyanotic or bluish in color. Okay. So if the doctor says 6 liters per minute, via nasal prong or the mask. So later, as we go along, we're gonna see all these equipments that we need for oxygen therapy. Okay. So again, whatever is the doctor's order, that's have to be followed. So factors affecting oxygen needs. So the altered function of any system affects oxygen needs. So anything that affects the respiratory system function. Okay, so some illnesses that any diseases that are that can alter the function, okay, of the heart, respiratory system that affects the oxygen need of the person. So oxygen needs are affected by respiratory system function. So airways must be open, must be adequate number of alveoli to absorb oxygen and excrete carbon dioxide. So if you can recall during our module 3 for the compensation of the heart and the respiratory system or your lungs. So can you remember when I mentioned about the oxygen exchange happens in the alveoli, the cluster of grapes. So it happens in the alveoli. So what if the alveoli for some reason are not healthy enough to have this gas exchange? So alveoli absorbs oxygen and it excrete or eliminate carbon dioxide. So if that one is not, if alveoli is not sufficient enough or it's not in an adequate number, so definitely the person will gonna what have problems. There's an altered function of this respiratory system or your lungs. Next is the cardiovascular system. It's your um, heart. So if you can recall the heart that has problem with, let's say, CHF, the closing of the valves. So if there's a pooling of blood, so definitely um, it's not adequate. Blood is uh, transferred to the lungs via pulmonary artery. So now, if there's not enough blood in the lungs to be for gas exchange, so definitely lesser um, uh, carbon dioxide are being excreted from the body, and lesser um, oxygen are being absorbed. So that's why when the person has CHF, the person has problems with breathing because the heart cannot pump adequate blood for this gas exchange in the lungs. Okay, so body systems depend on each other. So let me see here on our. Okay, so here we go. Let's go through here. Let me just pull out our book. All right. So again, this is our, if you can recall, This is our respiratory system. So this is the alveoli. Okay. So if for some reason there is a disease that affects the alveoli, so definitely um, the gas exchange is also altered or being affected. So let's go through the factors affecting oxygen. Okay. Let me see over here if I can. Let me see. All right. So I think it's better, right? All right. So respiratory system functions. So the airway must be open or patent, and there must be an adequate number of alveoli or single-celled air sacs in the lungs to effectively absorb oxygen and excrete carbon dioxide or the CO2, which is a waste product. Next, we have mentioned the cardiovascular system. So, oxygen is required by all cells to produce energy to carry out their proper functions, and blood must flow normally to and from the heart to all bodily cells. So, when blood vessels are narrowed by disease or other causes, blood flow will be constricted, capillaries and cells must exchange O2 and CO2 efficiently. Okay, so because of the blood flow is constricted, the gas exchange is impaired through the capillaries. Okay, next, red blood cell count. So blood must have enough red blood cells or RBCs, which are produced in bone marrow and contain hemoglobin. Hemoglobin contains iron and it picks up oxygen in the lungs and carries it to the cells. Health challenges that reduces RBCs in the blood include chemotherapy, leukemia, iron deficiency, anemia, and blood loss. So again, the iron is the one picking up the oxygen right into the circulation. So Houston, we have a problem if um, the red blood count is low. So again, tendency is also low capacity of picking up this oxygen, right? And then if you are okay with the red blood cell count, but again, the hemoglobin is low, which contains iron. Um, again, it will not pick up oxygen enough to provide this oxygen in the body. Okay, so next is the nervous system function. So again, when we say nervous system, the spine and the brain. So nervous system diseases and injuries can affect respiratory muscles, making breathing difficult or impossible. So brain injury as well as use of narcotics and depressant drugs can affect the respiratory rate, rhythm, and depth. So we have um, we have mentioned, right? The effect, the effect of let's say narcotics or antidepressant or depressant that can suppress the respiratory center, okay, of the body. That's why some people they overdose with drugs. They have a respiratory arrest. Next is aging. So respiratory muscles weaken and lung tissue becomes less elastic and advancing age, making coughing more difficult. So if the person cannot cough to remove secretions from the upper airways, pneumonia, for example, infection of the lungs can develop. So for this reason, older people are at risk for respiratory complication after surgery. So that's why after surgery, we really do encourage coughing, right? Because we don't want a person who just had a surgery will develop pneumonia, and it's very high risk for so with aging. Older people are at risk of developing pneumonia. Exercise. The body requires more oxygen when it is exercised to supply energy needed by the cells. So the oxygen demand throughout the body is usually met by increasing the respiratory rate and depth in the lungs. You're huffing and puffing. So have you noticed when you run like 100-meter race or just running out because you're scared of the dog barking? So there you go. You're gonna be huffing and puffing. It's because um, your body requires more oxygen. All right. So clients with heart respiratory disease may have enough oxygen while they are at rest, but with even a slight increase in activity, their bodies may not be able to bring enough oxygen and deliver it to the cells for energy. Okay, so this lack of oxygen stresses the heart and lungs, which, like all tissues, require oxygen to perform their necessary task. Fever. When fever is present, oxygen needs increase because the body is working hard to fight the infection that is causing the fever. So the metabolic rate also increases. So to keep up with the body's oxygen needs, the respiratory rate and depth must increase. Next is the pain. So pain increases the need for oxygen. So the body responds by increasing the respiratory rate and depth. Clients with chest and abdominal injuries or surgeries are unwilling or unable to take deep breaths because of the pain caused by breathing in and out, okay, which further increases their needs for oxygen. Okay, hold on. So here, the extra oxygen they need is therefore supplied to them by way of a mask or tube until they can take deep breaths on their own. Okay. So the next one is the drugs. So I have, as I have mentioned over here, right, the nervous system function. So drugs, narcotic, or a barbiturate overdose. So normally, when used as prescribed, the proper amount of drug will control moderate to severe pain. Okay. Provide also it provides a sedation. So the narcotics is the one controlling the pain, and then the barbiturate is the one provides sedation. That's why sometimes you feel when I had my coughing, okay, uh, problem that I cough. I cough like I don't know, like it's just like coughing and coughing. And I said I have to take something that it will suppress my coughing, a center. So the doctor gave me a codeine with this one. Okay, so he gave me narcotics with barbiturate that a little bit it sedates me. Okay, but again, this is a very teeny tiny. This is nothing like the one that you're like fentanyl, right? Or a morphine. So it's just small amount of codeine for targeting my respiratory center. So anyway, so I do that one and it's effective. But at the very end of the warnings, it says that you should take this one in the nighttime because it has this sedation effect, as well as you have to avoid driving or operating machinery. So I told my doctor I have to go to work, but I don't want my residents hearing me coughing because I'm very uncomfortable due to COVID, right? The COVID is during at that time, even though I have a mask, but it's so itchy. And he says like, yeah, you can do that one because I suggested if I can take just half. Instead of 5 ml, I'll take 2.5. So I usually take it the um, first hour of my shift so that I can last, right? It will last until let's say 3:30. So pretty much is the peak of this effect is already subsided. and I can drive safely. But 2.5 is really nothing, you know? Okay, so when a narcotic such as morphine or meperidine or demerol or a barbiturate is taken for recreational purposes, mixed with alcohol and other drugs that have not been prescribed or taken beyond the safe dosage. So the breathing center in the hypothalamus of the brain is affected, so the brain cannot tell the person to take deep breaths, so respiration are suppressed and become dangerously slowed or even stopped, possibly resulting in a loss of consciousness or death. Substance abusers are at risk for respiratory depression, breaths that are not deep enough to bring enough air into the lungs, or respiratory arrest, the stoppage of breathing from overdoses of these drugs. Okay, so another factor that affects the oxygen needs, we have smoking. So individuals who smoke inhale air that is mixed with harmful substances that can damage the lung tissue and have been proven to cause lung cancer and chronic obstructive pulmonary disease, or COPD. Smoking is also a risk factor for coronary artery disease. So next is allergies. So allergies, an allergy is a sensitivity to a substance, for example, pollen, dust, food, and drugs, or smoke, even, right? That causes the body to react with signs and symptoms such as runny nose, wheezing, or congestion. As part of the allergic reaction, the upper airways mucous membranes may swell. So, with severe swelling, the airways can close, resulting in shock and death. So, more commonly, however, people with allergies are at risk for chronic bronchitis and asthma. So, we have another one, pollutant exposure. So, a pollutant is a harmful chemical or substance in air or water. um, Air pollutants, for example, dust, fumes, toxins, asbestos, coal dust, and sawdust damages the lungs. So exposure to pollutants can occur at home, in the workplace, or in the community. Also, oxygen affecting oxygen needs is our nutrition. So good nutrition that includes iron and vitamins such as B12, vitamin C, and folic acid is necessary to produce what? Red blood cells, without which the body cannot transport oxygen to the cells. So we have to take good care of our red blood cells, right? So vitamin B12, vitamin C, and folic acid. Next is alcohol. So alcohol depresses the brain. Excessive amount reduce the coughing reflex and increase the risk for aspiration, which can cause obstructed airway and pneumonia. Okay, so let me continue later with that signs and symptoms. All right. So again, here we go. We did the red blood cells, right? We did that one. That chemotherapy can affect red blood cells, iron deficiency, the nervous system function, the aging, exercise, fever, and pain. Also, the drugs. We've read it. Depresses the respiratory center. Uh, the people with substance abuse problems at risk for respiratory depression or arrest. And of course, smoking, we just read that it can damage the lung tissue and causes chronic obstructive pulmonary disease. Allergies, yes, because if you are exposed to these allergens, okay, it can swell, the airways can swell, okay, and can cause chronic bronchitis, asthma, and death. So of course, pollutants can damage the lungs. Example is the asbestos. Mhm. There's a lot of. It was in the what, in the early 40s or 50s or 60s maybe, that they are people are using asbestos for their roof, and later on it was discovered that asbestos causes lung cancer. So I think they were compensated. And of course, alcohol. Okay, depresses the brain. So of course, it reduces the coughing reflex. Increase risk for aspiration. So respiratory function involves three processes. So the air moves into and out of the lungs. Okay. Oxygen, which is the O2 sat. Sorry, oxygen is or O2, and carbon dioxide or CO2. Okay, is they go both hand in hand. So we want the O2, and we're gonna disregard or excrete or eliminate carbon dioxide or the CO2 from the body. The blood carries oxygen. Sorry, the blood carries oxygen to the cells and removes carbon dioxide from them. So the CO2 exchange happens where? In the alveoli. So, what are the signs and symptoms, okay, of altered respiratory function? So, we have the shortness of breath, okay, SOB. Shortness of breath may be acute or chronic. So, when you say acute, it's a sudden onset. When you say chronic, it's persisting, it's on and off, okay? Also for chronic, it's gonna be with you. If you have shortness of breath, it can happen. For some reason, let's say you have heart problems, or let's say COPD, chronic obstructive pulmonary disease. So again, that is a chronic disease. So definitely you have also a chronic shortness of breath. Anytime, it depends on your activity level, right? Um, Shortness of breath or SOB, when unable to breathe, the client may feel very anxious, and also panic can occur. Short of breath on exertion, okay, SOBOE. So short, S is for short of breath on exertion. So these are abbreviations that you're gonna learn. But again, we don't really, some is SOB, but again, there's another meaning for SOB, right? But if you are in a healthcare setting, of course, we understand that it's shortness of breath. But usually, we don't really abbreviate that much. We just do like this. Ta-da! Shortness of breath. One word. Three words. Okay. All right. So, client often wants to sit up in bed or chair as it's difficult to breathe when lying flat. Okay. So, orthopnea, struggling to breathe is exhausting. So they want to be sitting up, okay, because it gives them a little bit of comfort when, what you call this one, when they are in sitting position. Okay, so next is never turn up the oxygen, okay, level beyond what is stated in the client's care plan. Never turn up the oxygen level beyond what is stated in the care plan. Because remember, these are, what you call this one? These are prescribed, okay, by the doctor. So we are not, even me, I cannot move it up unless, actually, for us, if the doctor were gonna say oxygen therapy, 2 to 6, 2 to 6 liters. So within that parameter, we can play around. It depends on the client's condition. So we can put on 3 to reach the, let's say, 95%. That's the doctor's order. So from 2 to 6 liters per minute, to maintain oxygen level above 95, equal or above 95. So if the order is 2 to 6, and then at number 3, okay, the patient is able to maintain the 95%, so we stay at the 3. But if they need more, the only maximum that we can give is until 6 liters. And if still deciding or O2 oxygen level still low, we call the doctor to change the plan. Okay, so again, as a healthcare, as a personal support worker, that is not your responsibilities. Okay, that's the nurse's responsibilities. All right. So let me see over here. Okay, so that's the one. All right. So signs and symptoms. Okay, so support workers needs to observe client for. Okay, signs and symptoms of altered respiratory function. You're gonna observe if there's any abnormal breathing pattern or shortness of breath. Okay, so if the client is coughing, observe how often, the frequency. Okay, is it intermittent or consistent? So productive or non-productive. So when you say productive coughing, so when I cough, you can hear like a phlegmy sound, like a wet sound. Okay, that is productive, especially if they are excreting, able to uh, the term for that one, expectorate. Okay, able to cough it out, the sputum. Okay, that is productive. But when it's a dry cough. You keep on coughing, 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 itchiness, no wet sound, no mucus, no sputum. That is non-productive. Okay, so you have to observe, is it productive or non-productive, is how often they cough, the frequency. Let's go to sputum. So the sputum, okay, when they cough when they cough and has this, let's say, the mucus, sometimes we're gonna say, here mucus, because I remember uh, those cough syrups. Okay, those cough syrups, they have to say, um it loosen the mucus, right? Loosen the mucus. So in a layman's term, we used to say mucus. I've spit so many greenish or yellowish mucus, right? But in a medical term, we use, when we document, is a sputum. Okay, so try to check, try to the way sometimes I do progress note, copious mucus, all right, or the sputum color, green colored sputum, or a yellowish colored sputum, right? So it depends on your observation. Is it like a scanty amount, or uh, large amount, or just a medium amount? So again, you cannot really have an accurate measurement for the sputum. Okay, so check the color. Is it like creamy? Is it white? Is it green? Is it yellow? And the odor, what is the odor of this sputum? Can you smell it? Our consistency, is it thin? Is it copious or thick green sputum? Okay, or is it bloody? For people with, let's say, lung cancer, or people with tuberculosis, they can uh, cough out bloody sputum, or hemoptysis. Okay, so hema again is blood. All right. So also, can you hear noisy respirations? Are they wheezing? Okay, so you use your senses. When it comes to observe, you use your senses. You have the sense of sight, hearing, smell, right? The touch, but we don't touch the sputum. Anything that your the anything that is from the person's body or bodily fluids, definitely you have to wear gloves. Okay, and of course they complain of what? Chest pain. Cyanosis. Okay, so you use your eyes. If the color, okay, is a bluish color of the lips, nail beds, skin, the mucous membrane. So when you the mucous membrane, let's say inside the mouth, right? Also changes in vital signs and the body position. So is the person sitting upright, or is the person leaning forward or hunched over a table in order to breathe properly? Okay, and of course for the chest pain, you're gonna ask the location. Is it come and goes? Is it constant or intermittent? um they if you can, let them describe the pain. Okay, so is it a stabbing pain, knife like, or aching pain? So of course, when it comes to the PQRST, all right, uh, pain tool. We're gonna learn that one in module 9. What makes it worst when you move? Coughing, yawning, sneezing, sighing, or deep breathing. That's the pain uh, makes it worst, or which position makes you feel way better or less chest pain. Okay. All right. So let's continue. Abnormal respiratory patterns. Okay. Usually, if the usually we've learned it from module, I think it's in module, hold on, module 2, chapter 25. We just recently vital signs 7 chapter 7. Okay, no, not chapter 7, module 7, the documentation. So we did discuss vital signs. Okay, module 24, not module, chapter 24, vital signs. So we know that adults normally have 12 to 20 respirations per minute. So infants and children have faster rates. Normal respirations are quiet, effortless, and regular. Okay, so that's why the when you take the respiration of the person, you usually leave your hand in the radial pulse area, okay, radial side, and then you try to observe the uh, rise and fall of the chest of the person. Okay, so both sides of the chest rise and fall equally. The medical term for normal respiration is eupnea. Normal. Normal breathing. Eupnea. Okay, so next is, all right, so let me go through this one over here. It's a little more detailed. Okay. So the abnormal patterns. So this is, we have tachypnea. Okay. So we have tachypnea, breathing faster than 20 breaths per minute. Okay. There you go. So when the person is tachypnea, it's rapid. Tachy breathing is nya, tachypnea. So respirations again are 20 or more per minute. So fever, exercise, pain, airway obstruction, and hypoxia are common causes of rapid breathing or tachypnea. Tachy means rapid. Breathing, nya. Okay, next is bradypnea. Brady means slow. Breathing again is nya. Bradypnea. So it means slow breathing. Respirations that are fewer than 12 breaths per minute. So the normal is 12 to 20. So lower than 12 obviously is bradypnea. Okay? So drug overdoses and nervous system disorders are common causes. And next is apnea. So a means lack or absence, and nya is breathing. Okay? So a is lack or absence. Have you heard the word sleep apnea? So there is a lack or absence of breathing when sleeping. So other people, they have to struggle, like, right? So they are snoring too much. That because they are struggle, or they stop. They really pause. There's a stop there for breathing. So of course, when the person stop breathing, definitely the oxygen exchange in the alveoli is also affected, right? So they have to have the sleep apnea machine to regulate their breathing when they sleep. So, apnea occurs in cardiac arrest and respiratory arrest. Sleep apnea in adults and periodic apnea in newborns are other types of apnea. Kushmal respiration, so deep and rapid respirations, and characteristic of diabetic acidosis or other conditions causing acidosis. That's why they have the Kushmal respirations. Next is hypoventilation. So hypo again is slow. Okay, same with here. Brady, hypo, they are slow. Okay, so hypoventilation, slow, shallow, and sometimes irregular respiration. So common causes include lung disorders such as pneumonia, that affect the alveoli. Other causes include obesity, airway obstruction, adverse effects of drugs, and nervous system and musculoskeletal disorders affecting the respiratory muscles. And next we have hyperventilation, or hyper is rapid and deeper than normal respirations. It many causes include asthma. See, when you have asthma, that is hyperventilation. Emphysema again is another uh, chronic disease in the lungs. Infection, fever, nervous system disorders, hypoxia, anxiety, pain, and some drugs. So let's go to dyspnea. Again, we know that this is difficulty, right? And nya is breathing. So difficulty breathing. So dyspnea, difficult, labored, or painful breathing. Heart disease, exercise, and anxiety are common causes for difficulty breathing. The next one is Shane Stokes. Shane Stokes are respirations that gradually increase in rate and depth and then become shallow and slow. Breathing may stop, okay, for 10 to 20 seconds. So, drug overdose, heart failure, renal failure, and brain disorders are common causes. Chains, Shane Stokes respirations are common when death is near. So this is the Shane Stokes. We usually my indicator when I see my resident having Shane Stokes respiration. That is an indication for me that death is imminent. Okay, or the death is near. Next, orthopnea, shortness of breath. Okay, when lying in a flat or supine position and ability to breathe comfortably, only when sitting or standing. So, common causes include emphysema, asthma, pneumonia, angina pectoris, and other heart and respiratory disorder that can cause orthopnea. Okay, so difficulty of breathing when they are flat on their back. They have to be sitting down, okay, in order for them to breathe properly. Okay, so hypoxia is a deficiency of oxygen in the cells. Okay, is one of the results of abnormal respiratory functioning. Hypoxia is caused by any illness, disease, injury, or surgery that affects respiratory function. Hypoxia is a life threatening condition because without enough oxygen to function, cells will be damaged. Okay? And the brain is very sensitive to inadequate supply of oxygen. So restlessness, dizziness, disorientation are early signs of hypoxia. It is important that you report signs and symptoms of hypoxia immediately, okay? Because sooner hypoxia is diagnosed, the sooner oxygen can be given, and the cause of hypoxia, um, and the cause of the hypoxia is treated. All right. So again, remember, when the brain doesn't have enough oxygen, it can cause what? Brain damage. Okay, brain damage. So let's see over here. We're already here. So signs and symptoms of hypoxia so includes restlessness, dizziness, disorientation, confusion, behavior and personality changes, difficulty concentrating and difficulty following instructions, apprehension, okay, or by an when you try to understand things, apprehension, anxiety, fatigue, agitation, increased pulse rate, increased rate and depth of respirations, sitting position, often leaning forward. Again, cyanosis is an abnormal condition evidenced in a light skin clients by bluish color in the skin. Mucous membranes, lips, gums, and around the eyes and nail beds are, bluish in color. So in darker skin clients, cyanosis may be easiest to see in the mucous membrane and nail beds. All right. And of course, dyspnea or difficulty breathing is a sign of hypoxia. So this is an orthopnic position. All right. So you're going to hunch over a little bit. put a table here. This is their the table in the resident's room or the patient's room, and they lean forward, put a pillow in order to promote breathing. Okay. All right. So let's continue with our slides. Everything is here too, but again, that the other one is more in details. Okay, here it goes. Shane Stokes. Or, all right. Here is hypoxia. We did that. So it's a life threatening. You have to report hypoxia if you observe the signs and symptoms. Okay, so promoting oxygen. So to get enough oxygen, air must reach the alveoli. So again, that's the cluster of grapes that where the what the oxygen exchange happens. Okay, O2 and carbon dioxide are exchanged. So disease and injury can prevent air from reaching the alveoli for some reason. Okay, so pain and immobility interfere with deep breathing and coughing. Also, narcotics can interfere with deep breathing and coughing. Measures to meet oxygen needs are common in care plans, okay, and it may include administration of oxygen, okay, so they're going to have oxygen therapy. Activities that involve movement, for example, a short walk, okay, in order to help expand the client's lungs. Positioning and rest periods is needed or recommended, right? Coughing and deep breathing exercises. And of course, the incentive spirometry, okay? Incentive spirometry. Okay, so let's go to positioning. All right, so over here, we're gonna assist breathing, okay, into the client sitting position, okay, so the semi-fowlers and the fowlers position. So clients who are sitting up can expand their lungs much more easier than when they are lying. Okay, so that is where the orthopnic position. So of course, we're gonna do a frequent position changes if it's needed, at least every 2 hours. Okay, use a reclining chair for the client's naps or sleeping. A reclining chair can enable the client to sleep in a partially upright position, which gives the lungs more room to breathe. Okay, so if the client is in the hospital bed, mechanically elevate the head of the bed to reduce the client's need to move in bed without help. Okay, so unless the physician has placed restriction on the positioning of the client should never lie on one side for long periods of time. Okay, so next, let's go to breathing and coughing. So coughing and breathing. So deep breathing moves air into the most parts of the lungs. Deep breathing and coughing, okay, help prevent pneumonia and atelectasis, which is the lung collapse. Okay, the lung collapses, so the term is atelectasis. And also, deep breathing and coughing removes mucus. A client may be reluctant to do exercises because of pain after injury or surgery or fear for breaking open an incision. So that's why if you remember before about the when you read documentation, remember, I think it's model 7 wherein the patient is lack of education, a lack of knowledge. I think deficiency or insufficient knowledge due to fear or due to lack of experience about surgery. Remember in module 7. So this is part coughing and breathing exercises are part of your health pre 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 operative and post-operative health teaching. It's not yours, but it's for the nurses. Okay, it's part of it in order for them to have this consent, informed consent. Okay, all right. So let's continue. They're scared that they're breaking open an incision. Okay, so post surgical period, bed rest, lung disease, and paralysis are factors for what? Atelectasis. Okay, a deep breathing and coughing may be done every 1 to 2 hours or 4 times a day as ordered, okay, by the physician. So let me see if um, assisting. Please read your um, book, okay, chapter 39, page 936, okay, assisting with coughing and deep breathing exercises. So pretty much this is the procedure in helping, okay. All right, so let's go to incentive spirometry. So, an incentive spirometry provides encouragement. Okay, incentive provides encouragement. A spirometer is a machine that measures the the amount or the volume of air inhaled. Okay, so oops, sorry. Here we go. So incentive spirometry is also called sustained maximal inspiration or SMI. So a spirometer again is the machine that measures the amount or the volume of air inhaled. So made up of breathing bag, it should be bag, not bug. Air chamber, an indicator that rises with each inhalation. So the client sees plastic balls or bars moved to different levels with degree of inhalation. Okay, so let me see where is that spirometry. Let me see if we have here. So we don't have it here, but later maybe I can find it. Okay, and show it to you. All right. So the goal is to improve lung function. Okay, the goal of the incentive spirometry. So again, incentive is to encourage. Okay, and then spirometry is a machine that measures the amount or volume of the air inhaled. So again, the goal is to improve lung function by taking long, slow, deep breaths. The client moves air into the lungs. Secretions become loose. Oxygen carbon dioxide exchange occurs between the alveoli and the capillaries. I think right now you already memorized this one. It's already in your system. Where is the uh, gas exchange? Where the gas exchange happens, you're gonna say, "Oh, it's in the alveoli." Okay, and capillaries. Okay, so the client takes slow, deep breaths until the balls rise to desired height, holds the breath for at least 3 seconds, and then exhales slowly. Sorry. So the care plan or supervisor gives instructions. Okay, so how often clients should use it, the desired height that the floating ball should reach, and of course the number of breaths needed. Okay. Oh, here we go. The client using this spirometry. We're gonna go through here. So I'm saying it should be here. It should be here. Okay. This is page 936. Okay, assisting coughing and deep breathing. This is the using the spirometer. Okay. So over here they're gonna breathe in, and this is there's some balls over here like the measurement. Okay, so for some I don't know what did they put here, but again it reaches a certain amount. Okay, so again if I'm not mistaken it should be the respiratory therapist, okay, helping with this one. Okay, next we're gonna go back to our slide. All right, so again over here the number of breaths needed, floating bowls. Okay, So, what is your role in oxygen therapy? So, oxygen is treated as a drug. We need doctor's order for that. Okay. For us nurses, before we have to ask the doctor for prescription. All right, it should be ordered. And later on, they decided that they want to give this. Uh, they have to revise the oxygen therapy in our unit, in our actually in the whole veterans, that nurses can initiate 1 to 2 liters. They can initiate for emergency 1 to 2 liters. So I'm gonna initiate. For example, my resident is static. Autosat is low. I can initiate max is 2. I'm gonna put 2 for now, and then right away while I'll did the nasal prong, okay, giving the oxygen therapy and wait maybe 10 minutes, all right, or so, and then check if the autosat or the 2 liters is helping before I call the doctor. So I'm gonna call the doctor. I'm gonna say I'm using the S bar, right? S bar when you communicate. Um, I have a 97 old male having autosat right now, has a history of COPD, uh, hypertensive. My autosat is down to, let's say, 90. Okay, down to 90. Initiated 2 liters of oxygen via nasal prong to the nose. Um, it was given 15 minutes ago, and then still is not working. Can you please assess? So the doctor will gonna prescribe 1 to 6 liters, either nasal prong or mask, okay, to maintain above or equal to 95%. All right. So next, some clients need oxygen constantly. So they have this. Have you seen those clients sometimes, or people? They have their, they carry their own oxygen. It's not a tank, but it's like a portable oxygen. Okay, and also others need if the symptom for symptoms relief. So support workers do not give oxygen. Okay, so they assist the nurse in providing safe care. Also, they are maybe trained to transfer oxygen. Okay, also provide oral suction. All right. So let me see over here. Let me see CBAC 39.4. 39.4. Where is that one? So please do check page 934. Okay, so you have all the positioning, the time management, also client care, other professional responsibilities. Okay, and as well as oxygen therapy. Okay, so oxygen is considered a class A compressed gas. So we know that women's regulation must be followed. Okay. So as a class A gas, it's again um, combustible. Okay. So you have to make sure that the combustible items such as clothing, towels, and sheets that are static charge should be away from the oxygen source, so that it reduce the risk for fire. Okay, and of course another um, important to remember that we don't use electrical, the electric, the shaver. Okay, it's because it can start a spark because it has battery, or it's being charged. So there's a charge. Maybe they can produce a spark, and then the client is in oxygen therapy. Of course, the risk for fire. Okay. So the three main delivery system is the oxygen concentrator, oxygen cylinder, and liquid oxygen system. All right. So let's move on over here. The oxygen concentrator. So the machine filters oxygen from the air into the room. It is plugged into a grounded electrical outlet used in facilities and community settings. So, machine filters oxygen. So, this is an example of a machine concentrator. This one, okay? So, I think I have one resident patient before that we have this one. We have a machine concentrator. So, it to um it makes oxygen, okay? It makes oxygen by taking in room air. It suctions the room air and filter out the oxygen, okay? So again, it must be plugged into the grounded electrical outlet, okay? So because the oxygen concentrator makes the oxygen, it does not need to be replaced or refilled regularly. It's because this machine is making the oxygen. Okay, it filters again. Um, when we breathe in the lungs, right? So the elimination of carbon dioxide. So this one it suctions the air, okay, and filters and delivers to the person. Okay, so next is we have. This is the one. Oh, the same thing in the book. Okay, so we have this one, oxygen concentrator. Next is the oxygen cylinder. So it contains compressed oxygen. The oxygen tank is placed at the bedside, used when clients are on outings. In hospitals and some continuing care facilities, oxygen is piped directly into person's unit through a wall oxygen outlet. So this is um over here. Okay? So this one is a portable oxygen that they can carry. Okay? This is an portable oxygen that they can carry. So we use this one for our clients. For example, they're gonna go for diagnostic, I'd say X-ray, and then they have to have oxygen therapy. So we have to put this one beside the wheelchair, or no, not the wheelchair, but the stretcher. But for the wheelchair, we have the like a bag, like a portable. We have the portable oxygen machine. Okay. All right. So hold on. Next is, let me see over here, oxygen sources. So this one are the tanks. Okay, so over here you have the PSI. Okay, zero it means it needs refill. So usually the PSI it should be in my unit. We just okay with the 2000 because 2000 says full. All right. And then when it's closer, it means that we have to have it refilled. Okay. So the gauge shows the amount of oxygen remaining in the tank. So this one over here, so pretty much half, maybe quarter full, right? Because over here 2000 is full, and then of course the client is using the oxygen. All right, next. Liquid oxygen system. A portable unity is filled from a stationary container called a reservoir. Okay. The portable unit can be worn over the shoulder. So this is the one that I'm trying to tell you. So this one, in my unit we don't have this, but in other units that a lot of residents using this portable portable oxygen. Okay, so we it's like a canister, like a female male, and then we're gonna attach it and then press this one, and then when it's full, it gives you the light that it's full, and then there's a strap that they can put it on their shoulder. We put it behind their a wheelchair, and then of course nasal prong, right? The tubing to their nose, and another one is we have the wall oxygen outlet. Okay, so later maybe we have it here on our slides. So remember, you assist with oxygen therapy. Assist again. You assist with medication. You do not administer oxygen as well. You do not administer medication unless you are delegated, right? So you are responsible for giving safe care to clients receiving oxygen. Always follow the safety guidelines. Okay? So let me see the safety guidelines in our book. All right, let me go over here. Let's go for the safety. So this is the wall. Okay, this is the wall outlet. So this is what we have. So have you seen the ball over here? This one, like a black, like I think it's black. Yeah, actually black. So this is the flow meter. Okay, so we adjust this one. So this one is one, two, three, four, until like 15. Okay, so the if the doctor orders one to three, so we'll either one is okay, but if we need more, we can titrate or increase the flow of the oxygen, but we can only go for the max of 3 liters per minute. If the client or the person still needs oxygen, more oxygen, so we have to ask the doctor to increase the flow. Okay. All right, so let's go to the safety over here. All right, so safety guidelines for oxygen therapy. Never remove the device, either cannula or mask, used to administer oxygen. Okay, because again, that's where the oxygen is flowing from the source to the nose, okay, into the airways. Report to your supervisor if the client removes the device. Okay, make sure the device is secure but not tight. Check for signs of skin irritation caused by the device. Okay, so especially behind the ears, under the nose when they're using cannula, and around the face if they're using mask. Also check the cheekbones because these tubings can cause pressure ulcer. Okay, keep the client's face clean and dry when the mask is used. Never shut off oxygen flow. Do not adjust the flow rate unless allowed by your scope of practice limitations and your employer's policy. Tell your supervisor immediately if the flow rate is too high or too low. Tell your supervisor immediately if the humidifier is not bubbling. Secure connecting tubing in place, tape or pin it to the client's garment according to the employer's policy. Make sure that there are no kinks in the tubing. Okay, there's no fold kinks so that the tubing is patent, that the flow of the air is adequate. So you're gonna make sure the client does not lie on the part of the tubing. Report signs and symptoms of hypoxia, respiratory distress, or abnormal breathing patterns to your supervisor immediately. Okay, so provide oral hygiene as directed, follow the care plan. Make sure the device is clean and free of what? Mucus. Maintain an adequate water level in the humidifier. Okay, so as we have mentioned about the fire, so let's go read the oxygen fire safety guidelines. So place no smoking signs in the room and on the door. Okay, remove smoking materials from the room, for example, cigarettes, cigars, pipes, matches, or lighters. Remove materials from the room that ignite easily, such as alcohol, nail polish remover, oil, petroleum jelly, or greases. All right. Keep the oxygen source and tubing away from the heat sources and open flames, such as direct sunlight, lit cigarettes, candles, lamps, stoves, heating ducts, radiators, heating pipes, space heaters, or kerosene heaters. Turn off electrical items before unplugging them. Use electrical equipment. Okay, use electrical equipment such as razor, radio, TV only if it is in good repair. Use only electrical equipment that has a three plug a prong 3 prong plug. Okay, whenever possible. Do not use materials that cause static electricity. Okay, such as wool or synthetic fabrics. Know the location of fire extinguisher and how to use them. If a fire occurs, turn off the oxygen. Then move the client to safety. Remind the client about oxygen safety, report safety hazards immediately. Okay? So over here, use electrical equipment that has three prong. Yes, use electrical equipment such as razor, TV, radio only if it in good condition. So when you go to your client's room, you don't really know if the razor is really, you know, in good condition. So just be mindful of this one, the electric razor. Okay, the chargeable one. All right. So next is, let's go to our slides. We did that one. We did this one too, but we'll go through with it. So oxygen and fire safety. Oxygen is flammable. So this oxygen is the number one, uh, you know, ingredient in starting a fire. So keep oxygen source away from heat and open flame. The physician, nurse, or respiratory therapist is responsible for for teaching the client and family members about oxygen therapy. So warn client of dangers and the safety hazard. Report concerns to supervisor. We did that one, the guidelines, right? So let's go to oxygen administration devices. So the physician orders the device to give oxygen. So these devices are common. So let's say the nasal cannula, simple face mask, partial rebreather mask, non-rebreather mask, as well as the Venturi mask. So let's go to let me see first if we have here the flow rate. Okay, so let me see the cannula. Later I have this in your book over here. Okay, so this is the nasal cannula. Okay, this is the nasal cannula. So it is used at home or in hospital setting to deliver oxygen to a client in need of extra oxygen. So it consists of a set of two prongs, which is this one over here, that are placed into the client's nostril and a plastic tube that fits behind the ear. So this one, the plastic tubing behind the ear. So that's why they said you have to check behind the ears because it can cause a pressure ulcer. Okay, and then sometimes they take it out. So make sure that it's adjusted in here, not too tight, not too loose. So I have one patient that she has sleep apnea. She needs oxygen supplementation through when she sleeps. Actually, when she's deciding, but you cannot really tell that she's deciding, but she's in the 80s. Okay, so for us we're already scared, but she's still talking. So she loves to take it out, and she doesn't do it in purpose, but she just like maybe it bothers her. So what I do, this is a tip, okay, but you have to ask your supervisor or one of the seniors, or the senior nurse, right, in your facility. So what I do is put a tape in here. Okay, put a tape to secure it, and then check the tape if it's red, or the skin for any reaction. Okay, so just to keep the thing in the tubing in place. Okay, so the prongs from the oxygen flow curve down to prevent drying of the sinuses. So the nasal cannula is connected to an oxygen tank or portable oxygen generator, or to the wall connection in a hospital through a what? Flow meter. So the one that adjusts? Okay, so that's the flow meter, which regulates the flow of oxygen. So the client can eat and talk with the cannula in place. So if the prongs are placed too tightly, nasal irritation can occur. Okay, as well pressure on the bones and then cheekbones. Okay, over here, this is your cheekbone. So just make sure. Sometimes, trust me, it embeds. Okay, it leaves indentation. Okay, so let's move on over here. So this is the face mask, right? The simple face mask. So let's continue. So moisture can build and under the mask, keep the client's face clean and dry. So masks are removed for eating. Usually oxygen is given by cannula during meals. So of course, if you're gonna see this, that the mask, okay, simple mask, Of course, you're gonna able to eat, right? So you have to take this off. You're gonna use the nasal prong in order for the client to, after eating, oral hygiene. Okay, and then you're gonna place the mask again. All right, so let's continue. So the flow rate is the amount of oxygen given. Okay, so it is measured in liters per minute. Okay, so let's say the doctor orders 1 to 3 liters per minute. So if I'm gonna document client's oxygen level is 96% via whatever is the equipment, either facial mask or venturi or the rebreather or the nasal prong at 2 liters per minute. Okay. Sorry. So the doctor orders 2 to 15 liters of oxygen per minute. So the nurse or respiratory therapist sets the flow rate. The nurse and care plan tell you the person's flow rate. Okay, so again, you're gonna read for some reason, especially in the home, maybe the client is making, deciding that they gonna, for example, the order is only up to 6, and the client is able to, thinking that it will help if they are gonna adjust the flow rate, but again, this is ordered. So that's why if from the previous slides, you're gonna tell your report to your supervisor immediately if the flow rate is too low or too high. Okay, so everything is in the care plan. Okay, next. So when giving care and checking the person, always check the flow rate. Tell the supervisor at once if the flow rate is what, too high or too low. A nurse or respiratory therapist will adjust the flow rate. Okay? So next is over here. Let me just show you the different types. Again, we mentioned about the equipments, right? We have the nasal cannula, we have the simple faced mask, we have the partial rebreather, okay, and this is the non-rebreather, okay. So again, if you're gonna see the difference over here, this is has holes rebreather, and this is non-rebreather, so there's no holes. Okay, so that's the difference. Because here, this is the rebreather. You're breathing on your own, and this one helps. But this one has no. This is non-rebreather mask. So this is the Venturi. Okay, this is the Venturi mask. So again, it depends on the level. So we have the color coded. Okay, again, this is not your scope of practice, but this is nice to learn, right? So different colors represent different types of flow rate. So for example, this is 1 to 2, and then and so on. Okay. So this is it. It has, you're gonna attach over here, and then this is the gives you the. I think the green is the highest one. I think the green is the highest one. Wherein there's a big the flow. It gives more oxygen. Okay. And this is where it attaches. So this is the flow meter over here, and it's attached to the wall. Okay. All right. So let's go back. Go back. So oxygen administration setup. So humidified oxygen. So if not humidified, oxygen dries the airways mucous membrane. So if it's not humidified, okay? So therefore, distilled water is added to the humidifier. So the humidifier is then attached to the oxygen administration system. Either is it wall outlet, oxygen tank, or oxygen concentrator to produce humidified oxygen, which is oxygen that contains water, so that we will avoid drying the mucous membrane. Okay? So oxygen safety. So you have to assist the nurse with oxygen uh, therapy. Again, the word is assist. Okay. So you do not give oxygen, but your supervisor may ask you to set up the oxygen administration system. So if that one is in page, let me see, which page is that? Setting up. You get it's page 944. Please read that one to give you an idea. Okay? So you do not adjust the flow rate unless allowed by your province, territory, and agency. Okay? Next is you must give a safe care. So let's go to assisting with assessment and diagnostic testing. So physicians order tests to find the cause of breathing problem and to prevent it from what? Becoming worse. The tests are performed by the following. So it could be performed by the physician, specially trained nurse, a respiratory therapist, or laboratory technician. So you will assist the client before and after the test as directed by the care plan and your supervisor. So we have the pulse oximetry. Remember, I did show you that little machine. So later in your book we have that one. Okay. So pulse oximetry is a device. Okay, or pulse oximeter. Sorry, is a device used to measure. Okay, the oxygen concentration in the arterial blood, as well as to measure pulse rate. So oxygen concentration in the amount, okay, of hemoglobin that contains oxygen. So usually our normal O2 sat, okay, or oxygen concentration in the arterial blood is from 95 to 100%. Okay, so for example, if 97% of all the hemoglobin carries O2 oxygen, okay, so tissues are getting enough oxygen, okay, because it's 97% of the oxygen concentration. But if the hemoglobin that carries oxygen only says 90%, okay, so the tissue are not getting enough what? Getting enough oxygen. Okay, so it depends on the again when we the factors, let's say the hemoglobin, the capacity of your hemoglobin, because the hemoglobin is the one carries the it contains iron, and the iron is the one picking up the oxygen and then what? Transport it to different cells in the body. Okay, so let me see. Oxygen concentration in the arterial blood. Okay, so again, 95 to 100. A sensor attaches to a finger, toe, earlobe, nose, or forehead may need to remove nail polish. Okay, a good sensor site is on the client. All right, so that is very very important. So when you say a good sensor site is on the client is important, it's because if their nail bed has nail polish, and sometimes we don't really see if it's cyanotic, if they are there are some reasons sometimes that to the point that we cannot get, we do with the earlobes. Okay, and sometimes this is the very ideal, the finger, the right, the um the index or whatever finger is available. Yes, this is, but sometimes also the toe, but sometimes we do the earlobe, especially for client for our resident that they're pretty much change of health status because they are dying. So we will see if how can we help with the oxygen therapy. Okay, for comfort. Next, use SpO2, okay, when recording the oxygen concentration value. S is saturation, P for pulse, and O2 is for oxygen. So when you write SpO2, okay, and report and record measurements accurately. So collecting sputum specimens. Sputum is mucus from the respiratory system. It is not saliva. Okay. So again, saliva is from your mouth. Sputum is from your airways. Okay. So you try to expectorate, cough it out. Saliva is just when you spit. That is saliva. Sputum. When you have this productive cough and you cough it out, and it has that copious or thick uh, um, uh, mucus out from your lungs. It can be colored yellow, creamy in color, or sometimes white. It depends. Okay, it depends on the diseases. Okay, that your lungs is going through. All right, and sometimes green if we are have this bacterial infection. So that is sputum, not spit. Saliva is a spit. Sputum is studied for blood microbes and abnormal cells that maybe can cause, the person has a CA, right? Non CA. So the client must cough up sputum from the bronchi and trachea. This can be painful or hard too. So do we have challenges, however, when it comes to let's say our clients who are already aging, right? Because as we age, our lungs tissue decreases, the lung coughing reflex is also decreasing, and also the lung cells are decreased, right? So everything is like a little bit slower. So they have problems with what? Coughing up sputum. So sometimes you can hear the gargling sound because they cannot cough it up anymore. Okay. So let's continue. So collecting sputum specimens. So specimens should be collected in the morning. Instruct the client not to use mouthwash prior to the procedure because of course when they cup it out, there you go, comes with what? Comes with the mouth rinse, the Listerine. Okay. So we have to you have to instruct that don't use mouthwash prior to the procedure. Provide privacy. The procedure can be embarrassing coughing out even for us sometimes here, right? When I cough and I can hear that mucousy sound, like a wet sound, I feel because sometimes I feel it's not embarrassed, but I feel bad that you guys are hearing it, because my coughing reflex is way more faster than my muting myself. Okay, so you can hear the sometimes the wet sound. So of course when somebody is like try to spit it out, the sputum, of course sometimes they feel embarrassed, so provide privacy. Okay, remember the dips, and of course we're gonna follow standard practices as well as wearing your what, using or wearing your personal protective equipment because we are handling what, um bodily fluid. Okay, so collecting sputum again. So we have the postural drainage. So some clients do not have the strength to cough out, okay, sputum. So postural drainage is required. Involves positioning the client to allow secretion to drain by what? By gravity because of their position, and makes coughing easier. Allows client to raise sputum. Okay, so chest percussion, chest clapping. Okay, you clap like the lungs with your hand, for example. You are clapping. Okay, that is percussion. It's a technique that loosens thick, sticky mucus trapped in the lungs. Sometimes when we, our child coughs, or even a family member coughs, right? And then we try to clap the chest. Come on, cough it out, because you try to loosen the thick, sticky mucus trapped in the lungs. So, if it is within your scope of practice for your province or agency, you may have to assist with postural drainage. So, let's go to the book over here. Let's go to our book. We see that already. This is the humidifier over here. Okay, that gives humidity, all right, into the oxygen. All right, so let's continue over here. We have the later with that one. We're gonna go through with that. This is the pulse oximeter. This is the pulse rate over here, and this is the SpO2, or the oxygen saturation in the arterial blood. Okay, so this is for the child, for the baby. Okay, so just to make the it has a sensor. Okay, checking the oxygen saturation in the infant. Okay, so here is the postural. drainage. Okay, so let's say this is the lungs and this has a mucus, right? So A, let me see, draining the right upper lobe. Okay, so draining the upper right upper lobe, and then B, draining the middle lobe. So this is the middle lobe over here, and the last one is the C is the draining the right lower lobe. Remember the right has three lobes and the left has two lobes, right? So have you remember before when I'm not really sure if you've seen it from the on the news during the COVID. I think it's in New York, in the hospital. They let their client have this postural uh, drainage position in order for them to breathe, in order for them to cough it out. They're on their prone position. Again, prone is on your stomach. Okay, that was the I think it's in the middle of chaotic of COVID-19 that we don't have enough vaccine yet. People are having difficulty breathing there in the hospitals. Okay, so let me go back, okay, to our you know what, let me go back to our book and then we'll read this one over here, the different diagnostic um test, okay? Respiratory test. So we have the x-ray, okay? So an x-ray of the chest taken to evaluate changes in the lungs. So we have also the lung scan. So it is performed to see which areas are not getting air or blood. The client inhales radioactive means giving off radiation gas, and is injected with the radioisotope. Okay. Radioisotope is a substance that gives off radiation. Lung tissue getting air and blood takes up the radiation active substances, and a scanner then senses the area with radioactive substances. Okay. So if you make sense out of this, so if this is the, for example, the lungs, right? So the lungs, this lung scan performed to see if which area are not getting air or blood, because the lungs should be filled with blood into the and air into the each and alveoli, right? And then that's where the gas exchange. So for some reason, there's part of the lung that is not getting enough air or blood. So no blood, no air. So this radioisotope, okay, so this substance fills in whatever part of the lung is not getting the blood or air. So that's where they can see that this part of the lungs is not functioning well, because the substance is taking up, okay, that part of the lungs that is not functioning well, so they can see on the scan. Okay, makes sense. All right, so let's go to bronchoscopy. Bronchoscopy. All right, there you go, bronchoscopy. So a scope again is it's a lighted, okay, a lighted instrument, okay, pass into the trachea and bronchi. So the airways structure are checked for bleeding and tumors. So tissue samples for biopsy are taken, or mucus plugs and foreign objects are removed. So after the procedure, the client is what? NPO. What is NPO? Nothing by mouth. Okay, so receives nothing by mouth and watch carefully until the gag and swallow reflex return, usually about 2 hours, because it goes to the scope, okay, goes to your throat, into your trachea, into the bronchi. So, of course, you have to rest your throat first before having a um, food. Okay, so nothing by mouth. All right, the thoracentesis. Okay, thoracentesis, the pleura or the thora is punctured, and air or fluid is removed, which is centesis from it. So thoracentesis is the pleura is going to be punctured, and take away the air or fluid, okay, from the lungs. So the physician inserts a needle through the chest wall into the pleural sac when injury or disease causes it to fill with air, blood, or fluid, and respiratory function is affected. So if you think about the composition of your lungs, so let me see. I think it's the very top. All right. So just for no, hold on, because I want to show you something that it's easier for you to understand. Okay, about this thoracosynthesis. I don't want to be too technical, but again, it will help you. Right? Okay, hold on. Okay, so let me proceed to page. Oh, hold on. Here you go. First few page. We have the picture of a lung. All right, there we go. So have you seen this one over here? The outer sac. So this is the pleura. Okay. So the thoracosynthesis is wherein they try to inject. All right, they're gonna puncture and take away blood or fluid from the pleura. Okay, that is pulling in there, caused by certain diseases. All right, let's continue. All right, so hold on. That's thoracosynthesis, right? Respiratory. You did that. Also explain that one. The different mask we did. Okay, so oh, what page is it? All right, so page 945. Oh, too far. 949. To go back up. All right, here we go. All right, so again, that is the thoracosynthesis. Okay, so again, the pleura, the outer lining or the sac, it's being punctured, and then air or fluid is being removed. Okay, so let's go to pulmonary function test. So tests that measure the amount of air moving into and out of the lungs, which is the volume. and how much air the lungs can hold, which is the capacity of your lungs. Okay, so the client takes a deep breath as possible and using a mouthpiece blows into the machine. The tests are used to evaluate clients' risk for lung diseases or post-operative lung complications and to measure the progress of lung disease and its treatment. So pretty much this is the um, either the recreational no respiratory therapist or the pulmonary doctor. Let's go to the arterial blood gases or ABGs. So puncturing of the radial or femoral artery to obtain arterial blood gases and measure the amount of oxygen in it. Hemorrhage from the artery must be prevented, so pressure is applied to the artery for at least 5 minutes after the procedure and longer if the client has blood clotting issues. Okay, so some of my residents, the doctor ordered for arterial blood gases or ABG. Okay, okay, if they have blood clotting issues. Okay, so let's move on to our um, slide. So, oh, artificial airways keep the airway patent or open. So sometimes, for some reason, we cannot breathe it on our own. We need artificial airways. So what they do, this artificial airways do. So these airways are kept okay patent by these artificial airways. So they are needed in the following circumstances. So we need artificial airways when disease, injury, secretions, or aspiration obstruct the airways. Okay, so we need this artificial airways. When the client needs mechanical ventilation, when the client is semi-conscious or unconscious, we need artificial airways in order for the airway to be patent or open. When the client is recovering from anesthesia. Okay, so intubation means inserting an artificial airways. So these types of airways are common. The oropharyngeal airway. So it is inserted through the mouth and into the pharynx. Okay. And then the other one is nasopharyngeal airway. So it is inserted through a nostril, um, endotracheal tube. Okay. So inserted through the mouth or nose and into the trachea. A cuff is inflated to keep the airway in place. And then there's another one is the tracheostomy tube. Ostomy is surgically opening, right? So of course it is inserted through a surgically created opening into the trachea. Cuffed tubes are common. So let's see over here in page, where is this? 949. Let me see, 49. So these are the artificial airways. So over here, picture A. Picture A is the, oh, I hope you can see. Maybe it's too big. Okay. So A is the oropharyngeal airway. So it's inserted through the mouth, right? And then there's another one is the nasal pharyngeal airway. Okay. To to your pharynx over here. So from nose and here is mouth, right? And then the other one is letter C is the endotracheal tube. So endo over here. And then there's another one is the tracheostomy. Okay, tracheostomy. So surgically opening. There's an opening over here. So later we can see. Okay, we can see some of the um, uh, tracheostomy. All right. So let's continue. So care of a client with artificial airway. So we have to check vital signs often. So we gonna observe for hypoxia and other respiratory signs and symptoms. If an airway comes out or is dislodged, Tell the nurse at once. So frequent oral hygiene is needed. Follow the care plan. Okay. So also we're gonna provide comfort and mesh and reassurance to the client. Also, we're gonna follow the care plan for communication methods. Okay. Always keep the call bell within reach. Use the touch to show you care if appropriate for your client's culture and ethnicity. So let's go to tracheostomy. Tracheostomy again is surgically inserted, right? Created opening into the trachea in order for them to keep the airways open. Tracheostomy are temporary, or it could be permanent. So a tracheostomy tube has three parts. We have the obturator, which is used to guide the insertion of the outer cannula. The inner cannula is inserted and locked in place, and the outer cannula is not removed. So the tube must not come out. Okay, extubation. A loose tube can damage the trachea. The tube must remain patent if the client is unable to cough up secretion. Suctioning is needed. So let's see here in your book. Where's my book? Over here. Tracheostomy. All right. So this is here. This is the outer cannula. Okay. So this is the outer cannula. This is the inner cannula. And this is the obturator. So again, the obturator is used to insert the outer cannula and then it is removed. So this one first. So this one goes in first through this. Okay. And this one stays behind. And this one is out. Okay. All right. All right. So for the outer cannula, okay. So the outer cannula, this one stays, and the inner cannula is inserted over here. Okay, inserted over here, and then this one is taken out, and then it's gonna be cleaned. Okay, um, if for example, there's a lot of mucus. Okay, there's a lot of mucus. Pretty much, this one is taken out, and then they're gonna do suctioning. Okay, all right. So this is a you might be remember if you um if you can remember the few slides that you might be is part of your scope of practice that you're going to be sectioning, right? So again, you're going to be trained. Don't worry, you're going to be trained by the agency. All right. So let me see over here. That's the inner cannula there. And we have, so over here, call your supervisor if the outer cannula comes out or is loose. So if this inner cannula, okay, the outer cannula is loose, you have to, okay, because this one, if it's loose, it moves around, okay, and it can damage the trachea. All right. So let's move on. Let's move on over here. Going down. All right. So let's read over here. Okay. Focus on children. So some children are born with congenital, means present at birth. So we've learned this one from developmental disabilities, right? Um, some of them have congenital conditions, and some of these conditions affecting the neck and airway, which requires tracheostomy. Some infections and foreign body aspiration can cause airway structures to swell or be blocked and obstruct airflow, so which necessitates emergency tracheostomy. Because again, tracheostomy is to provide patency of the airways. Okay. All right. So again, hypoxia. All right. You have to call your supervisor. So let me see. Maybe it's too big there. All right. So this is the trach over here. Okay. So this is the Remember, this is the flange, the outer, the inner. Sorry. No, the outer cannula, and then the inner cannula is inserted here. Okay, so right now it doesn't. Sometimes you have this imagination, but again, if you're gonna see it in person, it's totally different. Okay, and there is a sometimes they do, it's like a string, but I have cared for a client that has tracheostomy. She has a throat cancer, so she has this velcro for the uh, for the neck. Okay, so but I clean it every day. The the I take out the inner cannula, and then I have this just clean water. Yeah, just plain water. I clean it. Of course, there's a lot of and brush for the, sometimes the mucus gets stuck in there. But the more you are diligent to clean every day, the more it will stay uh, clean and patent. No mucus that is being dried inside. Okay. When I took the, maybe because I have, of course, I have a medical background, right? And when I took with this is one of my sidelines before caring for in a community. And when I went to this check up with her, the doctor mentioned that, oh, the trachea was perfect. It was so clean. So again, it depends on our hands how we care, right? So that is part of our job, how to care for this equipment that is attached to our client. All right. So where are we now? Okay, so we have that one. The tube must remain patent. So safety measures for clients with a tracheostomy, we read that one, right? That it should, there's a signs and symptoms of hypoxia or respiratory distress, or outer cannula comes out or loose, you have to call your supervisor. Okay, so nothing must enter the stoma. Nothing, only air. All right, so safety measures for clients with tracheostomy. So where is that one? Okay, so principles, we'll read that one later. Okay, so over here, follow standard practices when assisting with tracheostomy care. Okay, gloves, because again, you are handling bodily fluids, right? Tracheostomy care involves cleaning the inner cannula to remove mucus and then keep the airway patent. Cleaning the stoma to prevent infection and skin breakdown. So if you're gonna go back over here, Okay, so we take out this dressing. Okay, so remember that it's an surgically opening, right? So if it's surgically opening, hold on, let me see if I have. No, I don't have. So if it's surgically opening, if you're gonna take this out, there's the stoma, but we don't take this out. Okay, this one remains. So if you're gonna take out the dressing, you can see the skin, the surrounding skin of the trach. And sometimes it has it. The problem with the stoma sometimes because of this the mucus or the natural fluid of their body, sometimes it irritates the skin. So make sure it's pink in color. If there is the redness or swelling, you have to tell the supervisor because there's some irritation underneath this plastic over here. That's the reason why we put the gauze. Okay, we put the gauze. So the way I see it, for some reason, again, if you live in the city, maybe it's the nurses, they come and then change the dressing, but you might be delegated or you might be asked to um, do a tracheostomy care. Okay, all right, so let's continue with this is for the baby over here. All right, so let's continue. So cleaning the inner cannula to remove mucus and keep the airway pattern, cleaning the stoma to prevent infection and skin breakdown, applying clean ties or a Velcro collar. So there you go, the collar to prevent infection. Care is usually provided every 8 to 12 hours. Okay? So, safety measures for clients with tracheostomy: the trachea dressing should never have anything that can be inhaled. Okay, the stoma or tube should always be covered when the client goes out. So, I went to the because she is going through I think radiation or when we go out for a checkup, I saw some clients also, patients have a CA. They have scarf. Okay, they have scarf, so you will never know that they have trachea because they have this fashionista scarf, which is really helps with the person self-esteem, right? Um, and of course, when you say self-esteem, you feel about good about yourself. Of course, if people are seeing you with the trach in there and then on their how they perceive your condition, of course you can sense and then you can interpret um nonverbal nonverbal or body languages. So we don't want that, right? We don't want them to feel embarrassed because of their tracheostomy. All right, so cover a stoma with plastic or leather. Clients should take tubs instead of shower. Okay, water should never enter the stoma. Medical alert: jewelry should always be worn. So I have a client, the lady. She doesn't want the tub. Okay, she's 86. She doesn't want. She usually we do shower. Okay, so I let her sit on the shower stool. First, I cover the stoma with the saran wrap. Okay, I cover the stoma with the saran wrap so that it won't be, including the Velcro collar. Okay, and then if I have to Velcro collar. So before I leave, for example, she take a shower, right? So when I do dressing change, I let her hold the trachea itself. That's trachea, not the trachea, the outer the inner sorry the outer no the outer cannula where the it has this hold on, the flange, this one over here. I let her hold this one so that it's going to be in place. Okay, and I attach the Velcro over here and then wrap around her neck. Okay, so she's is my assistant. What's gonna work is teamwork. And then the older Velcro, I have to wash it and then hang it to dry so that the next day I can, or when I need it, I have a clean pair. Okay, so that is the I haven't done the string. The Velcro for me, it's way more. easier because it's easy to adjust, not too tight, not too loose. Okay, just go comfortably snug on the other person's neck. Okay, so let's go. Never should never enter the stoma. Medical alert jewelry should always be worn. All right. So now suctioning an airway. So secretions can collect in the upper airway, retain excretions, okay? It obstruct airflow into and out of the airway, provide an environment for microbes, the retained secretions, okay? So it can obstruct airflow, provide an environment for microbes to grow and cause infection. And also it interfere with oxygen and carbon dioxide exchange. And of course, if all these are altered, hypoxia can occur. Okay, or loss of oxygen. Person who cannot cough or have a cough that is too weak to remove secretion need suctioning. Okay, suction is the process of withdrawing or sucking up fluid, which is the secretion. So you can really tell that the person needs suctioning. It's because this one over here, it's full of mucus. Okay, so they have to do some suctioning. And then of course you're gonna be trained because you cannot just suction as you please. There is an interval. Okay, interval, because you don't want the client to having problems with breathing. Okay, hold on, let me see. Of course you're gonna be trained for that. In my case, we have a training just a few months ago when it comes to caring for trach, because we haven't done I think I have done once. That's it. I have done in my lifetime. I've seen so many tracheostomy, but I haven't done like suctioning. But right now, because the transition is acute, so we are uh, receiving more patients with tracheostomy. Okay, so let's move on over here. So the suction sites, so these routes are used to suction the airway. So we have the oropharyngeal, the mouth and the pharynx are suction. Okay, so that's the oropharyngeal site. The nasopharyngeal, so the nose and pharynx are suction. And then the lower airway, so the suction catheter is passed through an endotracheal or the tracheostomy tube. Okay, so pretty much in the tubing that they are um, inserting the suction tube. Okay, so over here, let's see. Safety measures for suctioning. So, safety measure for suctioning the airways. All right, we have that one. What else that I need to? Safety measures. Okay, so again, we have that. Never be covered with plastic leather. Okay, so hold on. Let me see over here. All right, should never be covered with stomach with plastic or leather. So let's go to tracheostomy care. Okay, let's go through with that. Let's go to our book. Tracheostomy care. All right, over here. So clients require care to their tracheostomy site when they are excessive secretion. So when the ties or collar holding their tracheostomy in place becomes soiled, or when dressing around their tracheostomy becomes soiled or moist. Such care is usually provided every 12 to 8 to 12 hours. Okay, so cleaning the inner cannula, so we're gonna remove mucus and keeps the airway patent. So cleaning is not necessarily with inner cannulas that are disposable. So there are some inner cannulas that are disposable. So all you have to do is take it out, dispose, and put a new one. But there are some cannulas that you need to clean. So that's my experience that I have to clean and then put it back. Okay. So cleaning the stoma. So it prevents infection and skin breakdown. And applying ties or the Velcro collar prevents infection. So remember, when the ties are removed, you need to hold the outer cannula in place. Okay, so the one with the flange that I showed you that my client is holding for me, okay, in place when I'm putting the Velcro collar. So the ties or collar must be secure but not tight, and you should be able to slide one finger or a finger under the ties, okay, or collar. So let's go through the children. So as with adults, in children, the ties must be secure but not tight. You should be able to slide only a fingertip under the ties. The ties are too loose if you can slide your whole finger. Okay, so only the fingertips. When assessing with tracheostomy care, you must hold the child still, position the child's head so that the neck is slightly extended. Okay? All right, so this is the ambu bag. Okay, they're helping the client. This is the trach, right? The ambu bag helping for breathing. Okay, so let's go. We did this one. Okay, so here we go. The suctioning. This is very important because you might be delegated. Okay, you might be delegated to suction. So if suctioning is not done correctly, it can cause serious harm to the client, as suctioning removes oxygen from the airway. The client may be unable to breathe during suctioning. Okay, and hypoxia and life-threatening complication can arise. The respiratory, cardiovascular, and nervous system can be affected, and cardiac arrest, infection, and airway injury are possible. It is your responsibility to ensure that suctioning is within your scope of practice for your province or territory and within your agency. Okay, so for sure, agency is going to train you because you're representing their company. The client's lungs are hyperventilated, giving extra, okay, breaths before suctioning for an ET or tube or tracheostomy. An ambu bag is attached to an oxygen source. Then the oxygen is delivery device is removed from the um, ET tube or tracheostomy tube, and the ambu bag is attached to the ET or tracheostomy tube. Okay, to give a breath, the bag is squeezed with both hands. Okay, so we have to hyperventilate first, more oxygen before we suction. Right, we put more oxygen first before taking away the oxygen. All right, so that the client will not be depleted of oxygen from the body. So they're gonna be hyperventilate first. Okay, so give a breath. The bag is squeezed with both hands. A nurse or respiratory therapist gives 3 to 5 breaths. So remember, oxygen is considered a medication and you do not administer medication. Therefore, you may operate an ambu bag attached to an oxygen source only if it is within your scope of practice. You are delegated. Some employers limit suctioning to 10 seconds and some allow 10 to 15 seconds for the suctioning cycle. 10 seconds. Seconds, we're talking seconds, right? So you're going to insert the catheter, apply the suction, 10 seconds or 15 seconds, remove the catheter. Okay? For infants and children, suction is applied for no longer than 5 seconds because, again, you're suctioning the oxygen from their body. It's not only the mucus, you're suctioning. So for us, even for us, when we do, it's not the trach. We're just suctioning because the client is not able to cough very gargly. We do suction their mouth. We give intervals, okay? Because we're suctioning the air. So they have difficulty of breathing too, okay? So you might be asked to assist a nurse with suctioning. So you need to understand the principles and safety measures involved in safety as suctioning. Okay, so we're going to read that one as we go along. Okay, so what's next in we did that one, right? Okay, safety. We did that one too, the ambu bag. Let's go to mechanical ventilation. So mechanical ventilation is using a machine to move air into out of the lungs, needed for a variety of of healthcare problems, including hypoxia, which is caused by weak muscle effort, airway obstruction, and damaged lung tissue, nervous system diseases, and injuries that can affect the respiratory center, interfering with messages between the lungs and the brain. Also, the drug overdoses that can depress the brain's hypothalamus or breathing control center. Okay, so here we go. Let me just check that one over here. The safety. Okay, hold on. All right. So an endotracheal, okay, endotracheal tube or tracheostomy tube is needed for mechanical ventilation, either through the mouth, okay, or through the your trachea, okay. Alarm sound when something is wrong. One alarm means the client is disconnected from ventilator. So when any alarm sounds, first check to see if the client tube is attached to the ventilator because it will give you an alarm, okay, which is smart, right? Because for example, you're not there in the room, um, you're in your other resident or your other client. Of course, when the ventilation is disconnected, it will just make an alarm. So when any alarm, again, first check if it is if the client's tube is attached to the ventilator. If it's not, attach it to the ventilator. Okay, if it's for some reason attached to the ventilator, then tell the nurse or supervisor at once about the alarm. Do not reset alarms. So this is good for those of you who are willing to work in a acute, for example, or maybe in a home too. They have tracheostomy, right? So you can have this chances that you're able to, encounter this. All right, so clients needing mechanical ventilation are very ill. So pretty much, they are in the acute setting. Okay. All right. So chest tubes. So let's go to chest tubes. So air, blood, or fluid can collect in the pleural space or sac or cavity. So remember the pleural space we already showed you earlier. So when the chest has been penetrated because of injury or surgery, what will happen? Pneumothorax can happen. So when you say pneumothorax, there's an air in the pleural space. Hemothorax, again, hemo is blood. So hemothorax, blood in the pleural space. And we have the pleural effusion. So pleural effusion is the escape and collection of fluid into the pleural space. I've seen a pleural effusion, so the lungs is a little bit fuzzy and cloudy. So it means that it is hazy. It means that there's a fluid in the pleural space. All right. Now let me see the book over here. There you go. Let's see mechanical ventilation. All right, so let's read first with the principles and safety measures of suctioning. Okay, so if suctioning is within your support worker scope of practice in your province or territory and at your agency, you should be taught the correct way to do it by a nurse or respiratory technologist. So again, it can be delegated to you, but before they can let you give the go signal that yes, you can, you're gonna do a for sure a return demonstration, right? You are knowledgeable and competent to do it safely. Review the procedure with your supervisor or a nurse. Know what is expected of you. Suctioning is done as needed or PRN. Coughing and signs and symptoms of respiratory distress signal the need for suctioning. Okay, so your supervisor will tell you what signs to look for. Standard practices. Okay, follow standard practices. Secretion can contain blood and are potentially infectious. So again, wearing of gloves, right? In some circumstances, a sterile technique must be used. Again, sterile technique, you have your own kit and then you have to follow the procedure. Your supervisor will tell you the size and type of the catheter, okay? To collect airway injury can occur if the catheter is too large. All right, so this is just the younger suction catheter. So this is usually used to if the client is not able to cough, very gargly. You can hear it just on the throat. So we try to let them cough and then suction on the side. Okay. All right. So next is needed suction equipment and supplies should be kept at the bedside so they are readily available when the client needs suctioning. So when suction is applied, air is sucked out of the airway. So suction should not be applied while inserting the catheter. The catheter is cleaned with water or saline after removal. All right. So where am I? So the catheter is cleaned with water or saline after removal. So the catheter should be inserted smoothly to prevent injury to mucous membrane. So the suction catheter should be passed um, inserted no more than 3 times. Okay, so the risk for injury increases each time the catheter is passed or inserted. So when suctioning, you should not suction any deeper than the client's oral cavity. Okay, so this means that the catheter should not go past beyond of the client's teeth or gum area. So suctioning near the client's epiglottis can trigger a strong gag reaction. So just over here, okay. Suctioning that far back is allowed in deep suctioning, which usually falls within the scope of practice only for nurses or respiratory technicians. So we're gonna check the client's pulse, respiration, and pulse oximeter readings, which is your SpO2 or O2 sat, right? Before, during, and after the procedure. Also observe the level of consciousness. Tell your supervisor immediately if any of the following occur. A drop in pulse rate. Again, normal is 60 to 100, so it means that less than 60 beats per minute. A drop or rise in blood pressure. Respiratory distress, okay, and a drop in the oxygen level, okay, O2 sat. All right, so this one over here, this is a mechanical ventilator. Okay, so if this one is detached from the machine, the machine will gonna alarm and it will let you know. Okay, all right. So let's go through before we enter the chest tube. We're gonna go through here. We're already here, anyways, right? Okay. So guidelines for caring for clients receiving mechanical ventilation. So keep the bell within reach in facilities. Make sure hoses and connecting tubes have slack. They must not pull on the artificial airway. Answer call bells promptly. The client is in a situation in which they must depend on others for basic needs. Explain who you are and what you're going to do whenever you enter the room. Give the day, date, and time every time you give air. Report signs of respiratory distress or discomfort at once. Do not change settings on the machine or recent alarms. Follow the care plan for communication. Since the client cannot talk, use agreed upon hand or eye signal for yes and no. All healthcare team members must use the same signals or confusion, not communication, may occur. Okay? Some clients may be able to use paper and pencils, magic slates, communication boards, and hand signals to communicate. So follow the care plan. Ask questions that have simple answers. It may be hard for the client to write long responses. Watch what you say and do, whether you are near or far from the client and family. They Pay attention to your verbal and nonverbal communication. Do not say anything that could upset them. Provide comfort and reassurance by talking to the client. It is also comforting when you talk absolutely light topics such as weather, pleasant news about gifts, and cards. Meet the client's basic needs, follow the care plan, use touch to reassure and comfort the client, tell the client when you are leaving the room and when you will return. Okay? So that is the guidelines for caring for clients receiving mechanical ventilation. So pretty, they are receiving this because they are very ill. Okay, so mechanical ventilation in home care. So home care is often arranged for clients receiving mechanical ventilation. Portable ventilators are used in home care. So if you are caring for a client on ventilator, a nurse will teach you how to care for the client. Family members are also taught how to assist with the client's care. Always make sure that a nurse is available by phone when you are in the client's home. Okay, so just in case you're gonna do some troubleshooting. Okay, all right. So over here, so let's go to test tube. Okay, not test tube, chest tube. So the chest tube is a hollow plastic tube surgically inserted into the chest cavity, which allows the removal of trapped air. Okay. What else? Air or blood, right? That is trapped in the pleural space or in the pleural sac. So we also um, discuss about the pneumothorax. When you say pneumo, there's an air inside the air's pleural space, hemo, blood in the pleural space, and then water or fluid collection in the pleural space, which is the pleural effusion. Okay, so let's see that one. So pressure occurs when air, blood, or fluid collects in the pleural space. So the pressure collapses the lung. Air cannot reach affected alveoli. O2 and CO2 or the carbon dioxide are not exchanged. Respiratory distress and hypoxia will result. Also, pressure on the heart threatens life. The doctor inserts chest tubes to remove the air, blood, or fluid. Okay, so chest tubes are inserted in order to remove air, blood, or fluid. And the tube, okay, the chest tubes are attached to a drainage system. So the system must be airtight. Water seal drainage keeps the system airtight. So how do we care for the test tube? Okay, let me see. Caring for the chest tube. Oopsie. No, over here. This is what I am. All right, so this is an example of chest tube. Okay, so it attached into the pleural space to remove air, to remove or blood, or maybe pleural effusion. Okay, so let's see, go back, remove the air. Okay, so remove the air to drain fluid. Okay, this is the fluid, this is the air, this is the fluid over here. Okay, and let me see. This is the pleural space. Have you seen the yellow one? Right. This is the pleural space, and this is the test tube. Why I keep on saying test tube? Chest tube. All right, chest tubes. Okay, are inserted. Okay, or maybe one. Either it depends where is the and then what is the cause? Is it caused by blood? Is it caused by air? It is caused by fluid accumulation. Again, all right. So this is the chest tube inserted and drains. Okay, and then there is a oh, they didn't see it, but there's a machine that collects the drainage. All right, so let's go to the guidelines for caring for clients with chest tubes. So keep the drainage system below the level of the client's chest. Absolutely, it's the same logic when it comes to the urinary drainage bag. It should be below the bladder, or else there's a backflow, right? Check vital signs as directed. Report vital sign changes at once. Report signs and symptoms of hypoxia, complaints of pain, difficulty breathing, and respiratory distress at once. Keep the connecting tube coiled on bed. Allow enough slack so the chest tubes are not dislodged, okay, when the client removes. So if tubing hangs in loops, drainage collects in the loop, okay. Often a set of sterile forceps are trapped near the client's bed in case the chest tube is accidentally pulled out and an emergency reinsertion is necessary. Ensure the forceps are kept near the client at all times, even when being sent for a test such as X-ray. Okay, prevent tubing kinks. So when which can obstruct. Sorry, when it's kinking, it can obstruct the chest tube, causing air, blood, and fluid to collect in the pleural space. Observe chest drainage. Report any change in the chest drainage at once, including increases in the drainage or the appearance of bright red drainage. Record chest drainage according to employer's policy. Okay, so please don't get overwhelmed with this guidelines. You're gonna be trained. You're gonna be educated. You're gonna be, uh, informed. Okay, turn and reposition the client as directed. Be careful and gentle to prevent chest tubes from dislodging. Assist the client with coughing, deep breathing exercises as directed. Assist the incentive spirometry as directed. Note any bubbling in the drainage system. Tell your supervisor at once if bubbling increases, decreases, or stops. Tell your supervisor at once if any part of the system is loose or disconnected. Keep sterile petrolatum gauze that at the bedside. If it is needed if a chest tube comes out. Call for help at once if a chest tube comes out. Cover the insertion site with sterile petrolatum gauze. Stay with the client and then follow nurse's direction. Okay. All right. So let me see. We did that one. All right. So hold on. Is there anything else that we miss? So that is the promoting oxygenation. Okay. And we're gonna do the review the questions. All right. So number one, alcohol and narcotics affect oxygen needs because they A. Depress the breathing center in the brain, B. Are pollutants, C. Cause allergies, and D. Cause a pneumothorax. So the correct answer is letter A. Alcohol and narcotics depresses the breathing center in the brain. That's why it affects the oxygen need. Okay? Next, hypoxia means A, lack of oxygen, B, not enough oxygen in the cells, C, not enough oxygen in the blood, or D, the amount of hemoglobin that contains oxygen. So hypoxia is not enough oxygen in the cells. Okay, so of course the cells cannot function well. So letter B is the correct answer. Next, number three. An early sign of hypoxia is A. Dysphagia, B. Cyanosis, C. Restlessness, or D. Decreased pulse and respiratory rate. So, restlessness, okay, letter C is the correct answer. Restlessness is an early sign of hypoxia, which is not enough oxygen in the cells. Number four, a client can breathe deeply and comfortably only while sitting. This state is called, remember, when they're just sitting, they can lie down. A. Bradypnea. B. Orthopnea. C. Biot's respirations. D. Kushmal respirations. So we've learned today that client can have a breathe deeply and comfortably only when sitting. Okay, so this state is called orthopnea. All right. Next, which of the following is a sign of altered respiratory function? A. Joint pain. B. Nausea and vomiting. C. Severe abdominal pain. Or D. Wheezing or crowing sound. So again, respiratory wheezing is part of the respiratory, not the joint, not nausea or vomiting, not severe abdominal pain because that is gastro, right? So altered respiratory function is wheezing or crowing sounds. Letter D. Number six, a client's SpO2 is 98%. Which of the following is true? A. The client needs suctioning. B. The pulse oximeter is wrong. C. The client's pulse is 98 beats per minute. Or D. The measurement is within the normal range. So the correct answer is letter D. The measurement is within normal range, right? So 95 to 100. Okay, next. Which of the following is a common site for pulse oximetry sensor? A. Is it your wrist? B. Your index finger? C. Upper arm? Or D. Second toe? The common site. So the correct answer is letter B. Index finger. All right. Next, number 8. The best time to collect sputum is on awakening, B. After meals, C. After bedtime, or D. After the suction. All right. So if you're gonna recall about collecting the sputum, of course, when they wake up in the morning, and then make sure they don't use mouthwash, right? When we gather the or collect the sputum. Next, number 9. A sputum specimen is needed. You should ask the client to A. Use mouthwash. B. Brush the teeth. C. Apply lubricant to the lips. Or D. Rinse the mouth with clear water. So I just have mentioned that no mouthwash, right? So we're gonna let the client rinse the mouth with clear water. Number 10. You are assisting a client with coughing and deep breathing. Which of the following is true? A. The client exhales through pursed lips. B. The client should do this just after eating. C. The client exhales deeply through the nose. Or D. The client needs to be in a comfortable lying position. The correct answer is letter A. The client exhales through pursed lips. Okay, next. Which of the following is useful for deep breathing? A. Chest tubes. B. Pulse oximeter. C. Incentive spirometer. Or D. Partial rebreather mask. So the correct answer is the incentive spirometer. Okay, it's helpful for deep breathing. Number 12, you are assisting with oxygen therapy. You can A. Start the oxygen. B. Decide what device to use. B. C. Turn the oxygen on and off. Or D. Keep the connecting tubing secure and free of kinks. So the correct answer is letter D. Keep the connecting tubing secure and free of kinks. Number 13. A client has a tracheostomy. Which of the following is true? A. The outer cannula is removed for cleaning. B. The obturator is inserted after the outer cannula. C. The outer cannula must be secured in place. Or D, the client is rarely at risk for aspiration. All right, so the correct answer is we've learned that the outer cannula must be secured in place either with a string or with a Velcro collar. Okay, number 14. A client who has a tracheostomy can do the following: A. Sing. B. Shave. C. Shower. Or D. Swim. So the correct answer is letter B. Okay, shave. All right. So this one with water, no water, it should not be wet, and of course they already have difficulty of like talking, so they cannot really sing. So shave, absolutely, they can shave. All right. Number 15. A client has a tracheostomy. For the client's safety, the old ties are removed after A. The stoma is cleaned. B. The dressing is removed. C. The inner cannula is removed. Or D. the outer cannula is held in place. So number 15, the correct answer is letter D. Okay. So the old ties are removed after the inner cannula is held in place. Okay, number 16. These statements are about suctioning. Which of the following is true? You can perform the procedure without wearing gloves. B, suctioning is done every 2 hours. C, suction is applied while inserting the catheter. Or D, a suction cycle is no more than 10 to 15 seconds. So we did learn that a suction cycle is no more than 10 to 15 seconds. Okay? Number 17, chest tubes. A, insert air into the lungs. B, remove trapped air from the chest cavity. C, are artificial airways. Or D, provide mechanical ventilation for the client. So which one, a chest tube is what? The correct answer is letter B. It removed trapped air from the chest chest cavity. Okay, so that is the purpose of chest tube. All right, next. Number 18. Which of the following is used to hyperventilate the lungs? A, is it an ambibag? B, pulse oximeter. C, incentive spirometer. Or D, partial rebreather mask. So the correct answer is ambubag. Okay, so the ambubag is used to hyperventilate before suctioning. All right, number 19. Mr. Long requires mechanical ventilation. Which of the following is true? A, he cannot move. B, his call bell is useless right now. C, you can reset alarm on the ventilator. Or D, he has an endotracheal or ET tube or a tracheostomy tube. So, of course, I'm 100% you choose D because we just learned it today, right? You just recently being, given all this information about ventilation. So, endotracheal or ET or tracheostomy too. All right, number 20. An alarm sounds on Mr. Long's ventilator. So what should you do first? A, reset the alarm. B, ask him what is wrong. C, call your supervisor immediately. Or D, check to see if his airways is attached to the ventilator. So we just learned a few minutes ago that if the ventilator machine alarm sound. So you're gonna check if the airways is attached, okay, to the ventilator. If it's not, you're gonna attach it, okay, and tell the nurse in charge or call your supervisor. 21. A client has a pneumothorax. Which is the collection of what? We have the pneumothorax. Is it air in the pleural space? B, is it blood in the pleural space? C, is it fluid in the pleural space? Or D, respiratory secretion in the pleural space? So we have just learned that pneumothorax is the collection of air in the pleural space. Okay, so letter A is the correct answer. Number 20. Chest tubes are attached to a disposable water seal drainage system. You should do the following. A. Encourage the client to stay in bed. B. Hang the tubing in a straight a line as possible. C. Keep the drainage system below the client's chest. Or D. Reinsert the tubing if it is accidentally disconnected. So the correct answer is letter C. Keep the drainage system below the client's chest. So it's the same thing with the bladder, right? So below um, the urinary tube, drainage should be below the bladder. So okay, so that is all for our chapter 39, promoting oxygen. All right. So thank you everyone for this opportunity of learning today.